Good morning, good afternoon everybody. So it has been a very early morning for all of you, and it is my pleasure to be able to talk to you, all of you today. So what is actually radiology and why it is important for PG medical entrance exam? That is what I'm going to talk about, and I'll give you an idea which to me is very important. When I was in your age, in my second year MBBS or third year MBBS, I did not know that a department called as radiology existed. I'm sure many of you would have been first of all exposed to the radiology department today, or maybe when you went on a tour, or maybe you will go on a tour today. But when I was in third year MBBS, I had no idea that there is a department called as radiology. But when I look back, and when I became an intern, and when I look back, I saw radiology was everywhere. It was hidden. Did you all see the latest edition of Gray's Anatomy, or your anatomy textbooks, your Robbins pathology? If you look at the textbooks of your undergraduation, you will find they are all scattered with radiology images, which we comfortably as undergraduate were ignoring. We never thought this is radiology. And then when we look back, as a radiologist, the biggest challenge that all of us have is actually we have to learn the anatomy all over again. We have to read the pathology all over again. It's like, it was always there. So radiology is not, a short subject any longer. And I want to tell all the undergraduates who are listening to me today that many of you believe that, radiology is a short subject. It will contribute to a few questions in your exams. But actually, when we look at radiology, it's a part of every subject that you do. And all of this has become more and more relevant with the evolution of the exam pattern in India. Till 2022, we had an exam which was happening on paper. The PG entrance exam was happening on a piece of paper. And you had those bubble sheets. How many of you are aware of bubble sheets, that where you have to blacken the A, B, C, and all those things? When we print a radiological image on a paper, the image gets distorted. We are not able to see the finding. Like for example, you were seeing miliary tuberculosis on the screen. If you see it on a computer screen, it is better seen. But if you print that X-ray on a paper, that small finding will get distorted. So till 2012, there were no visual questions in Indian PG entrance exams. There were no visual questions, and the radiology questions were also more one-liners, more fact-oriented. In 2012, the government introduced a computer-based exam, and now the exams started to happen on computer screens. On a computer screen in radiology, can I ask all of you a question? What is CT scan? What is the full form of the word CT scan? Computed. So what is computer? Computer. So radiology is married to computer technology. So when we brought computer technology into the exam system, radiological images became more and more a part of the exam system. Not only radiology, even pathology images started to be asked in the exam. Now when we say radiology questions in your exams, they do not mean one-liner, they actually mean image-based questions. Like you saw in the quiz, identify the disease, identify the cavity, identify pneumothorax. So you have to find the problem. Then the next thing that is about to happen, and I'm sure you are all reading the newspapers with a lot of focus, and you're all actually excited about, or maybe worried about a RTI reply that was recently filed regarding I don't know if you've heard of the exam or not. Can I ask you which exam am I going to talk about? NEXT, yes. So now there is a new talk that MBBS graduates after their MBBS are supposed to appear for a licensing exam called as NEXT. And in the new curriculum, and I'm so happy that Dr. Solanki, Dr. Ramanand, my teachers, they have all initiated this initiative for medical students to understand clinical radiology. So important thing to follow is that now the government wants you to have early clinical exposure, which is the basis of competency-based medical education curriculum. And you will have an exam at the end of your final year, which will be your licensing as well as your PG entrance exam. And this exam, again, you will see an evolution happening, and which is where I'll try my best to explain to you. which is where you will have more need to connect the dots. So what do we mean by connecting the dots? The radiology, I told you, is a part of almost every subject that you have studied. So we have to connect it. But in the exam, when we look at a question, this is how most of the questions will be. There is a question which has a stem, like you saw, there was a 3 or 4 liner question. There will be choices and there will be an image. Now, my first trick that I wanted to share with you all is, whenever you see an image-based question, what do you look at first? Do you look at the image? Do you look at the choices, or do you look at the stem of the question? What will you look at first if you are doing an exam and you want to get the best score out of an exam? What should you see first? Image, or choices, or stem of the question? Anybody? Now, the biggest mistake the medical students do is they look at the image first, and then when they're looking at the image, they keep thinking about, ये X-ray में, is this pneumonia, is this pneumothorax, is this chest X-ray, is it MRI? You're thinking of thousands and thousands of things. But actually you have to only restrict your thought process to 4 choices, because those are the only 4 choices that have been asked in the exam. This is exact opposite to what we do in clinics. When I look at an X-ray for reporting in my clinics, I look at the X-ray without looking at the history, so that I'm not biased by the history. I make my mind, then I look at a history to corroborate and answer some questions that I have in my mind about the diagnosis. But when I look at an MCQ, I look at the choices first, so that I am restricting myself to 4 choices. Are you clear or not? So that I am not overthinking into it. So I have hundreds of time I have interacted, probably even thousands of time I have interacted with medical students. The problem is they look at an X-ray and they are thinking of so many things which are not even asked, and you are wasting your time. All these smart students who top the exam, they look at the choices, they restrict themselves to those 4 choices, they look at the stem of the question only to rule out from those choices, they look at the image to rule out choices. I'll explain to you. Now let's look at the image. Okay, I'm showing you an image similar to what we saw in the question, but different diagnosis. Anybody looking at the image, what do you think we are looking at? Is it a X-ray, CT, MRI? X-ray, very good. Is it a diseased X-ray or a normal X-ray? Disease, definitely disease. Is it an infective process, neoplastic process, or congenital process, metabolic process? What do you think? Now you're thinking too much. This is not required out of undergraduate in an MCQ exam. MCQ exam should have been actually the opposite. Look at the choices first. And that is one trick that all the toppers are using, nobody is telling you. Everybody is thinking toppers are super brilliant, they know how to diagnose and all. They are just ordinary MBBS graduates who only know that I have to think on those 4 choices. Now, do you see any metabolic choice in the question? No. So should I think that rickets hai, hyperparathyroidism? Should I think, I should not be thinking. I'm a smart student, I want to pass the exam, become a radiologist. I don't want to become a radiologist in the exam itself. I want to become a radiologist based on the results. So anybody, now tell me, is this, so all the 4 choices are bone lesions. Osteosarcoma is a malignant tumor, like I saw in one of the questions, you had a choice also. Sarcoma, the word sarcoma is scaring me. When you say sarcoma, sarcoma, very malignant. So it should be more infiltrative into the bone, it should be more permeative, it should be spreading outside the bone, there should be periosteal reaction along the Sharpie's fiber, there should be sun-ray appearance. Do you see any of this? No. You see more localized. It doesn't look like as sinister as a sarcoma would. You would rule out. Hear me out. The second key word of an MCQ exam is rule out. You don't know it, it is okay. You have to rule out. You're not a radiologist, you are a medical student, but you want to get 10 out of 10 in the exam, rule out. It is not osteosarcoma. What are the 3 choices left? Osteoclastoma, aneurysmal bone cyst, simple bone cyst. Now, bottom 2 choices are cysts. Because my talk is primarily around MCQ, so I'm not going to go into the length, but these are cysts. Simple bone cyst was the one which your professor showed you, where you had a pathological fracture. Simple bone cyst is seen in adults or children? Simple bone cyst, adults or children? Okay, this particular X-ray is a child or adult? How do we know? We have to look for growth plate. If the growth plate has fused, we are looking at an adult. Look at the question, the choice, the first line, age, 22-year-old. It's not a child. So it is important to understand simple bone cyst is seen in children. Even if I don't know how to look at an X-ray, that is ruled out. Aneurysmal bone cyst and osteoclastoma are going to be two expansile lesions. But again, aneurysmal bone cyst is more commonly seen in children in metaphysis, while GCT or osteoclastoma is an epiphyseal lesion, expansile, eccentrically placed. What do you think is the answer? Osteoclastoma B. So the entire idea is that don't overthink into it. There are only two keywords in an image-based radiology question. Number one, look at the choices first. Number two, try to rule out even if you don't know it. It is okay. It is okay not to know. I am with all humility telling you I don't know everything, and any radiologist you meet, any professor you meet, any senior doctor you will meet, everybody will be humble enough to say medicine is much bigger than any of our lifetimes. So we do not know it all, but we try to rule out like smart people. So radiology is not a short subject. We need to develop an integrated approach. Integrated approach means there are two levels of integrations that are important for your next exam as well as for your NEETPG and your current pattern also. Vertical integration, horizontal integration. Anybody, what is horizontal integration? If I integrate anatomy with cardiac physiology, it is horizontal. If I integrate cardiac anatomy with clinics, with the radiology, it becomes vertical. I'll show you. So let's look at a question. I hope you're able to read it, yes. So what is this style of question? This is a clinical vignette. Clinical vignette means you will have a long stem question with 4 choices. This is the method which is now being proposed for NEXT, as well as if you go abroad and appear for USMLE exams, you will have questions like this. Scary? Which subject question is this? Let's try to find out. 53-year-old man brought to emergency department for evaluation of fever, chills, malaise, so looks like emergency medicine. Cardiac examination reveals a murmur. Blood sample for routine cultures are obtained. He has a transesophageal echo done. Ultrasound probe is kept in mid-esophagus facing the anteriorly. Cardiac chambers are interrogated. Anatomically, which of the following cardiac chambers is closest to the probe? Which subject now? Actually, it's an anatomy question. I'll explain. This is how, if you are able to see my green arrow, you will be able to see esophagus. This is where esophagus is on a cross section. Which cardiac chamber is posterior-most? Marked by my blue arrow? Left atrium. And which is towards the right? Right atrium. And what is my yellow arrow showing us? It is your right ventricular outflow tract. This is the anatomical image. This is not a radiological image. And the only thing I want to emphasize today is do not look at radiology as a separate department. Look at it as a part of everything that you're doing. That is what is attracting toppers to radiology, because they like to be a part of everything. Now tell me, everybody, please answer my question. Look at the image now and tell me, if you put an echo probe in the esophagus, which cardiac chamber will be closest to the esophagus? Left atrium, because that is the posterior most part of the heart. The answer is left atrium. This is how we put a clinical blanket, make it look like a clinical question, but actually the answer lies in your basic sciences with little bit of radiology thrown into it. I'll show you one more image just to make sure that you understand. Small question, large question? Big question, very big. Scary? Yes. Sorry, ये तो नहीं होगा. Let's try to see. 40-year-old man, accident, emergency department, severe headache of his life, worst headache of his life. CT scan shows subarachnoid hemorrhage as shown in the image. What is the most likely site of ruptured aneurysm? Okay. So I'm sure when you were discussing in the morning today, we talked about sulcal hyperdensity, sulcal spacing having the blood will be your SH. Okay, subarachnoid hemorrhage, which is already mentioned in the question. Question is, where is the SH? Were you able to pick up? Anyone of you? Are you able to see this area where we see blood? What is this area? This is your Sylvian fissure. Right side, left side? Right side, left side? Left side. Now what happens is, when we look at a CT image or a radiological image, you're standing on the foot end of the patient, facing the patient. So the images look, you're actually facing the image. So your right is not the right, it is on the other side. So this is the left-sided Sylvian fissure bleed. What artery? The question is, what is the site of ruptured aneurysm? So again, anatomy question. So this is the anatomy diagram that you were studying in your Snell's anatomy, Gray's anatomy, that internal carotid artery divides into anterior cerebral artery, middle cerebral artery. Middle cerebral artery goes between the frontal and the temporal lobe. It gives lenticular branches to the basal ganglia, then goes into the Sylvian fissure, gives a superior branch, inferior branch. So we know middle cerebral artery is in relation to the Sylvian fissure. In this patient, the blood is localized to the Sylvian fissure, which is answerable if we see the image. So what is your answer? Middle cerebral artery, left middle cerebral artery aneurysm. What is the topic of the question? Anatomy again. So the interesting part is that this is how anatomy should have been thought of, and somewhere we do a mistake that we think radiology will be something different, surgery will be something different. I'll show you one more question just to make sure that we understand. A patient is being evaluated for recurrent UTI. Abdominal CT scan is shown. Which of the following structures prevented the proper ascent of the anomalous organ seen on the CT scan? Anybody could diagnose what is the problem on the CT scan? So can you see this white structure here? What is this? Kidney. But then it looks to be more anterior than the normal position, more medial. And what is this? Isthmus. It seems to be connected to the other side, shaped like a horseshoe. What is this? Horseshoe kidney. But is this a radiology question? No. Because you are supposed to identify this horseshoe kidney. You've already done it. The question is integration. The question is, kidney develops in the pelvis. From pelvis it ascends upwards. It goes upwards. But when it is ascending upwards, if you have a isthmus in the center, what will happen? The ventral branch, lowermost ventral branch, will not allow it to go up. Please see this diagram now. The arrow is now pointing to the artery called as inferior mesenteric artery. So the horseshoe kidney, when it is ascending up, cannot go above the level of inferior mesenteric artery because it has a isthmus in the center. What is the answer to the question? Inferior mesenteric artery. Radiology question? Embryology question? We can't say, it is integrated. So the entire thought process of medical education today is that we are not looking at subject. Now, I want you to get this entire artificial divisions that have been made in your mind, that this is anatomy, this is biochemistry, this is pathology. In the end, you will see one patient. The patient would be surgical patient, medicine patient, everything inside him. Everything is interconnected. And that is the new approach of medical education, system-wise approach. Look at cardiac system with 360 perspective. Look at brain with 360 perspective. I'll show you one or two more questions. Just to show you the new pattern. This is a tougher question. If you are able to answer, pretty good. If you have, anybody wants to try out the answer, I will be very happy. 35-year-old female, acute dyspnea. During the past 6 months, she had mild dyspnea. She is not a smoker. At that time, the chest X-ray was showing pneumothorax. Now a CT scan is done. Which of the following is the likely diagnosis? I am giving you one choice, which is saying Langerhans cell histiocytosis. Anybody? Can you have Langerhans cell histiocytosis in the lung? Yes or no? LCH in the lung? This is a very tough question because the exam has to identify the toppers also. Na? It is not just to pass, it is also about to find somebody who is going to top the exam. So, can you have LCH in the lungs? Yes or no? So, when you go back to your Robbins pathology, you will discover it was written there. LCH can happen in the lung, but in smokers. Langerhans cell histiocytosis of the lung happens in smokers. And when you smoke, the smoke goes up, goes to the upper lobe predominant. While in this case, you have a lung-based CT with cystic spaces in a female who is not smoker. LCH is ruled out. Again, hear me. Toppers are not answering any question. They are all ruling out. Other students are thinking कि उनको सब आता है, मुझे कुछ नहीं आता. They are ruling out. Non-smoker. It is not LCH. Alveolar proteinosis. Did you read about one MCQ in your pathology? Alveolar proteinosis, macrophage function problem leading to surfactant-like protein getting accumulated in alveolar spaces with appearance, with a typical appearance which is given in your pathology book. Crazy pavement appearance, which is not there in this particular CT. Lymphangioliomyomatosis. Have you heard of this word before? Okay. Have you heard of tuberous sclerosis before? Tuberous sclerosis, autosomal dominant, autosomal recessive. Autosomal dominant condition called as tuberous sclerosis, which is associated with multiple, tumors in the different body parts. One is which are classified under the category picomas, perivascular epithelioid cell tumors, which include angiomyolipoma, lymphangiomyomatosis, clear cell sugar tumor of the lung. So try to see the logic here. Cyst and lymphangiomyomatosis is almost exclusively seen in young females. Look at the first keyword that I have highlighted in the question. 35-year-old female, premenopausal female, non-smoker, everything with the history of pneumothorax. So when you read LAM on your Robbins pathology or in your medicine book, you will find it will say patient will have episodes of pneumothorax or chylothorax. All this will fit into the story. Again, the only reason I got this question here is to show to you that whatever you are ignoring might become a differentiator in when you have to get into the top ranks. Very quick question. You saw one case of RCC with lung metastasis. Remember you saw it in the quiz? Okay, my question is, adolescent male comes to you with hemoptysis, chest x-ray is shown, what do you think of? Okay, so this is a very important X-ray. Once, I saw a similar X-ray in my own practice. It shows cannonball appearance, young male, and the X-ray came to me when I was in Vimhans. It came to me with a history saying known case of tuberculosis on treatment. But the X-ray was like this. What is this? Cannonball appearance. When do you see cannonball appearance? When you have metastasis. Young male. So, but my history was saying tuberculosis. The history sheet that you get in radiology is saying known case of tuberculosis. What should I do? What is the job of a radiologist? You will say write the report. But the job of the radiologist is to give answers to the questions which have been asked. And I was not satisfied with the question that was asked. I called the patient that I want to meet you. Are radiologists supposed to meet the patients? Are we supposed to meet the patients? What do you think as students? Answer is yes. World over now, radiologists are gradually becoming more and more clinically oriented, and there is a lot of talk about communication to the patients. So I called the patient, I said, I want to talk to you. Do you think I got respect from the patient? No. The patient said, I will talk to my doctor, who are you? Can you imagine that? But should I get angry? No, I often see when during my LHMC days, the girls, when they would go into a hospital, there would be some patient relative would say, sister, and they will get very angry, I'm a doctor. So now a similar situation I find myself. I'm a radiologist, I'm calling a patient, I want to talk to him, I'm saying, I'm asking him a question, but he's saying, why should I talk to you? I will talk to my doctor. He's not taking me to be a doctor. What to do? There are two choices. Either I gain his respect by my knowledge, or I gain his respect by scolding him, but that doesn't really work. So what I did was I asked him a quick direct question. I said, I think you have a scrotal swelling, I want to examine it. With his pants on. With his pants on, I said, you have a scrotal swelling. He said, young male, and he said, how do you know Dr. Sahab? So can you immediately see the respect flowing? Now he says, how do you know Dr. Saab? Now he knows that I'm a Dr. Saab, because I know in a young male, if you see lung metastasis, top of the line, you need to remember it could be testicular tumor. And then he said that, uske liye I am showing some other doctor. This particular hospital, I have come for my TB treatment, which is causing blood in my sputum. Connect the dots. I called and then I want you to understand, I called up the pulmonologist. I said, Dr. Saab, I am a new radiologist, I have joined this hospital, I wanted to talk to you. He said, I am not free, I am busy seeing patients. Respect? No respect. No respect. You don't get any respect until you show your worth. I said, I know Dr. Sahib, you're busy, but I just wanted to tell you that you had sent a patient of tuberculosis from your practice to me. I examined the patient, I saw a scrotal mass, I have changed the diagnosis. I think this is a testicular tumor with lung metastasis, and this is how it should be. And I just wanted to introduce myself. I am Dr. Sumer Sethi. He said, sorry, I didn't get your name. So this is how you make name, by connecting the dots. If my job would have been over if I said known case of tuberculosis, no significant serial interval changes, the game would be over. So radiology is about connecting dots, answering questions. For example, this is a case of HIV where you have cystic spaces in the lung, and we made a final diagnosis of cryptococcal. And the final question I wanted to show to you is this. This is a corollary to the question that you learned today in the morning when they taught you MRI. The fat will be bright or white on both T1 and T2 weighted image. So this particular question, there is a lady, young lady at nexal masses, MRI shows high signal on both T1 and T2 weighted image. What it could be? Fat. Ovarian mass with fat, ovarian tumor with fat. Or if I add calcium, tooth, could be dermoid. But read the next line. On fat suppressed T1 weighted image, the lesion remains high signal. That means it is not fat. The fat is not getting suppressed. What could it be? So always remember, there are two things which are bright on both T1 and T2. One is fat, second is blood products. Blood products, what could it be? Endometrioma. The answer was endometrioma. So the entire idea is the exam system has evolved, but have you evolved your thinking process? It is not just about content, it is also about your MCQ skill and your mindset. So I tried my best to show you that what do we mean by content. Today you learned a lot of content in the morning, but then you need to develop your MCQ skill to put it. Then you have some mindset. You need to know radiology is not a boring subject. It is something that toppers are opting for. And many times I meet medical students, they will say toppers are going for radiology because they want easy money, which is not true, which is actually not true. Can you tell me who earns the maximum money in the hospital? You will say radiology, but it is not true. It is surgery. Actually, surgeons make the most money, but radiologists, they connect a lot of dots. So why good students are going to radiology is because of the variety. They like to, if you see in my talk, I talked about multiple systems, brain, ovaries, much bigger than whatever you will learn in your lifetime, not just now. So stop getting angry. I keep meeting young students who start getting angry, कि अरे मुझे तो ये आया नहीं, मुझे तो आता नहीं था. I'm telling you, you will keep getting this feeling your entire life. You have to change your mindset. To do well in your exams or to do well in your life as a doctor, we need to know I have to learn every day. I might make mistakes, hopefully they should not harm anybody majorly, but you might make mistakes, but you will have to keep learning. And whatever you're learning today and anatomy, in pathology, you feel कि ये पता नहीं कभी काम आएगा कि नहीं आएगा, but there will be a time when you will look back, you will find everything will connect. But till that time you need to keep moving forward. Till that time, because I see sometimes I meet second year students like you or third year who say, sir, मेरे से connect नहीं हो रहा, because you have not seen the entire journey, ना? It happens, the connecting the dot happens when you look back. And my quick take-home messages for you are: radiology is no longer a short subject for MBBS. Integrated approach is the key. In future, the exams will have more clinical vignettes. Images will play an important role. Image-based questions need a more common sense approach. There are two buzzwords for image-based questions. Look at the choices first. Even if you don't know the answer, rule out. Don't be bogged down. This is what radiologists also do. We rule out. We rule out in our mind, this is not infection, this is not, we rule out. Radiology is a marriage of technology that you learned in the morning and you will see in the afternoon, medicine, and it has basis in your pre and paraclinicals. It is a connected science. Finally, the only thing I would want you to know today is that even if you are not able to follow anything that you're learning today, keep following your gut feeling. There's something right, there's something destined for you which would happen in due course. You need to just keep following your passion. I resigned from neurosurgery in AIIMS to join radiology here because I wanted to do radiology. and I always loved radiology. Till today I love radiology. So I would say please follow your passion. Don't be bogged down by names, labels, anything. What would matter in the long run is if you are happy doing what you're doing. I wish you all the very best. You all deserve a big hand for yourselves. Thank you very much.
Thank you so much, Dr. Sumer, for that very, very interesting talk. If you could I would request Dr. Raman, ma'am is a director professor in our Department of Radiology. She's the former Vice Principal of Lady Harvey Medical College and the former HOD of our department. I request ma'am to please felicitate Dr. Sumer.
God bless you. It's so nice to hear you and so great. That's how I feel.
Thank you.